publications and literature for treatment-resistant depression. Then we will review the mechanism of action, therapeutic use, drug efficacy, and dosing of ketamine. And lastly, we will apply the information learned from the presentation to the patient cases. So to start off, our patient case, we have MM, who is a 22-year-old female with a history of depression who presents to her PCP in March of 2021 for a follow-up appointment. Her family history is significant for depression in her mother and her aunt. She did come to you in December of 2020 and took a PHQ-9, and her score was 16. Now she's here again in March of 2021 with a PHQ-9 of 18. Her current med is sertraline 150 milligram tablets, 1 tablet daily. And at this appointment, she states that her mood was improving, but with recent stressors, with COVID-19, breaking up with her partner, and school troubles, her mood has been decreasing and getting worse. So what would you change about her treatment? We have A, increase her dose to 200 milligrams, B, switch her to a different SSRI, C, add on bupropion as an adjunct, or D, diagnose her with ketamine, with treatment-resistant depression and give her ketamine. I am not seeing anything in the chat. I'll give it a few more seconds and I'll move on. Okay, so the answer we chose here was to add on bupropion as an adjunct agent. And so this is just kind of setting the scene for the fact that mood disorders, depression, treatment-resistant depression is definitely an art, not a science. She is already at a therapeutic dose of sertraline, and she has not met any criteria for treatment-resistant depression. For answer choices B and C, there could be an argument made for both. But with answer choice B, she has stated that she was improving on sertraline therapy. And so we're under the assumption that maybe some of these stressors have been the cause of her mood decreasing. We don't have to assume that sertraline is not working for her, that maybe an adjunct agent is what she needs to continue to boost up her mood. So we wouldn't switch her from a different SSRI, but instead add on an adjunct agent like bupropion. And so we'll review what major depressive disorder is, also known as MDD. And so major depressive disorder is a disabling illness that is associated with frequent relapses, incomplete recovery between depressive episodes, and persistent psychosocial and functional impairment. It affects up to 1 out of 5 adults in the US, and is one of the 10 leading causes of disability worldwide, and is also associated with an increased risk of suicidal behaviors. Up to 2 out of 3 patients with major depressive disorder will not respond to the first medication that's prescribed to them, and approximately 30% of these patients are resistant to conventional treatments. The estimated economic burden attributed to major depressive disorder in the United States was $120 billion in 2020, and this was inclusive of direct medical and pharmaceutical costs, suicide-related costs, and effects on workplace productivity. The symptoms of major depressive disorder are pictured here per the DSM-V criteria. And so a patient must have 5 or more depressive symptoms for 2 or more weeks, and the symptoms are there in that red box to the right. The patient must have either displayed depressed mood or loss of interest or pleasure in their daily activities. These symptoms must cause significant distress or impairment, and they must not display any manic or hypomanic behavior, as that starts to fall into other mood disorders such as bipolar. Regarding the pathophysiology of major depressive disorder, it is still undefined and unclear. According to the monoamine hypothesis, depressive symptoms are mainly related to a deficit in the synaptic availability of monoamines and neurotransmitters, and most antidepressant drugs are working to modulate these systems to increase the availability of these neurotransmitters. And that is things like norepinephrine, dopamine, serotonin, and more. And major depressive disorder can be related to genetic factors, the patient's neurobiology, environment, and other factors. So now we'll move on to what are the usual treatment guidelines for major depressive disorder. And we'll start off with tricyclic antidepressants. And so these have a long record of efficacy in the treatment of depression. However, they're used less commonly because of their side effect profile and the fact that if used in an overdose, they can be extremely toxic. They do work to inhibit the reuptake of serotonin and norepinephrine in the synaptic cleft to increase these neurotransmitters. And they have an extensive side effect profile, including cardiac, anticholinergic, and antihistaminic effects, as well as they decrease the seizure threshold, can cause diaphoresis and tremor in patients. Next, we have the monoamine oxidase inhibitors. So these were actually one of the first types of antidepressants developed, and they're really effective in a broad range of affective and anxiety disorders. However, they do have an unclear mechanism of action. They're thought to increase dopaminergic, noradrenergic, and serotonergic neurotransmission by inhibiting the monoamine oxidase enzyme. And they're not commonly used due to, again, their side effect profile and the risk of hypertensive crisis. Patients on these agents have to follow a low tyramine diet due to that risk of hypertensive crisis. And other side effects on these agents include insomnia, anxiety, orthostasis, weight gain, and sexual dysfunction. Next, we have everyone's favorite, our selective serotonin reuptake inhibitors, also known as SSRIs. So these are first-line agents just due to the general efficacy, tolerability, and safety of these drugs. They inhibit the serotonin reuptake pump and increase postsynaptic serotonin receptor occupancy. General side effects that patients may complain about is dry mouth, nausea, headache, insomnia, and loose stools due to the low serotonin receptors in our gut. Some may also complain about effect of sleep, also increased weight or appetite. And so the nice thing about these medications is that patients can move from one medication to another within the same class and see better efficacy and tolerability. Next, we have the cousin of the SSRIs, our serotonin norepinephrine reuptake inhibitors, SNRIs. So we know these are also commonly used for things like nerve pain, but they can be used in major depressive disorder. They block the presynaptic uptake of serotonin and norepinephrine, and they have similar side effects to SSRIs, but they can also cause an increase in blood pressure. Usually these are dose-dependent side effects, commonly seen with venlafaxine. Next, we have a few atypical agents. These can be used for initial treatment, but also used as adjuncts as displayed in our patient case earlier. And so we have bupropion, which is also used for smoking cessation and seasonal affective disorder. It inhibits the presynaptic reuptake of dopamine and norepinephrine. However, it does have contraindications in seizure disorders and eating disorders, as it does lower the seizure threshold. It can also cause dry mouth, tremor, and insomnia. Next, we have mirtazapine. Mirtazapine can also be used as a sedative, an antiemetic, and can be used for appetite stimulant effects. So this one antagonizes the presynaptic alpha-2 adrenergic receptors and the postsynaptic serotonin receptors. Due to the indications of mirtazapine, it also kind of leads into the side effects that are seen. And so that can be dry mouth, drowsiness, as well as appetite increase and weight increase. Next, we have our serotonin modulators. So the common one that I know I've seen here is trazodone. It can mostly be used for sleep, but it does have off-label indications for anxiety, Alzheimer's, substance use, bulimia, PTSD, and more. There are other serotonin modulators that are more indicated for depression listed below. Trazodone works on postsynaptic serotonin receptors and weakly inhibits the presynaptic serotonin reuptake, and does have quite a few side effects such as headaches, fatigue, dizziness, QTC prolongation, and others. Next, we have all of our agents that are usually used for augmentation or adjunct therapy. So the first being lithium. Lithium actually has the best evidence in terms of combining it with tricyclic antidepressants for major depressive disorder. However, there is growing research on the effectiveness of it with SSRIs. It is currently underutilized just due to the risk of suicidal ideation and the need for lab work to ensure that there are proper levels for the patient. Next, we have serotonin dopamine activity modulators. And so these are our brexpiprazole and our aripiprazole. They work on serotonin, dopamine, and noradrenaline receptors. And they can be used as adjunctive therapy. They're beneficial for sleep, cognition, and more, but patients do complain of an inconsistent effect depending on who is using it. And lastly, we have our second generation antipsychotics. And so that's clozapine, olanzapine, ziprazone, and more. They are investigated to be pretty great adjunct agents. However, they do come with quite a few side effects, especially the metabolic side effects that patients find undesirable. And so MM was started on an adjunct agent, and now we are going to see her again. It is after a year. It's now June 2022, and she presents to our ED for suicidal ideation. She says that she's been struggling with finding a job after graduating from school. She has a fear of the pandemic, and her self-confidence is suffering. She does have a plan. Her current medications are now bupropion, nortriptyline, quetiapine, and clonazepam as needed. She has been considered to have failed sertraline, escitalopram, citalopram, and lithium therapy. However, with her lithium therapy, it was just due to poor tolerance of the side effects. So right now, the current plan is to admit her for stabilization and for her own safety. So what would you change about her treatment? Would you start fluoxetine, reattempt lithium, start ECT therapy, or start ketamine therapy? Okay, we have a quiet group today, but that's not a problem. And so this is the point where we would start to consider ketamine therapy. Seeing as how she's failed these other SSRI therapies, starting fluoxetine is probably not going to be the most beneficial for MM. We could attempt lithium. However, due to her poor tolerance, she might not be the biggest fan of that. And she's also had a few other adjunct agents added on. We could consider ECT therapy. However, there are other options that we should probably try before we get to that point. And so ketamine therapy would be something that's appropriate for her at this time, and we will talk about why. And so treatment-resistant depression, what is it? Treatment-resistant depression is commonly described as the inadequate response to at least 2 trials of antidepressant pharmacotherapy. Treatment-resistant depression is also the cause of recurrent, prolonged, costly periods of inpatient treatment to stabilize and ensure the safety of the patients. When considering a diagnosis of treatment-resistant depression, it's important to consider pseudo-resistance in the patient. And so what that is if a patient has gotten suboptimal doses, they weren't able to get to the true therapeutic dose of the agents they were on, or they didn't have a thorough enough trial, so at least 6 to 8 weeks to start seeing some kind of effect from the therapy. So any premature discontinuation, whether that be due to side effects, adherence, or other factors. We want to make sure that patients did give each therapy a fair shake before giving them this kind of term of treatment-resistant depression. We also want to make sure that there's no comorbidities that could be the cause of their depression and that could be treated and relieve this issue. So that could be things like thyroid disorders, looking at the patient environment, if they had a cancer diagnosis, just evaluating the holistic view of the patient. The last thing to note here is treatment-resistant depression is actually not an official diagnosis in DSM-V. However, there is a lot of research into the topic, but because of this lack of official diagnosis, this does lead to inconsistent diagnosing and staging of the disease. So when discussing staging, there are actually 5 published staging models for treatment-resistant depression that all give different weights to factors like treatment failures, duration of unresponsiveness, symptom severity, whether or not ECT was used, and more. When looking at the factor of treatment failures, this usually includes either the number of agents or adjuncts that were used and whether or not the dose was appropriate. So we have a few different staging models here. The one that I came across the most in my research was a Maudsley staging method. And right now, these tools have been researched to stage the treatment-resistant depression severity in these patients. There is no real research and documentation on using them to track general patient outcomes and progression of therapy. And so here's an example of the Maudsley staging model in our patient. And so here they have a severity criteria of mild, moderate, and severe. And so for our patient, for example, you can look at the duration, and she has been battling this for within the subacute period. So she first appeared in December of 2020, is now June of 2022. And so she would get a 2 here. Her symptom severity, she is severe, however, without psychosis. She is battling suicidal ideation. She has a plan. She has a lot of other symptoms that are going untreated right now. She has currently failed 3 to 4 antidepressants. She has gotten augmentation, and she has not used ECT. This would put her in that moderate criteria for treatment-resistant depression severity. So when finalizing the diagnosis of treatment-resistant depression, you want to first confirm the diagnosis of major depressive disorder. Then you want to determine the degree of resistance, so using a staging criteria to see where that patient is. And lastly, you want to use a clinical confirmation tool to assess the overall severity of the depressive episode. And so 2 of the more common ones that I saw in research were the Montgomery-Åsberg Depression Rating Scale, so MADRS, or the Hamilton Rating Scale for Depression, so HAMD. Here is an example of the MADRS clinical confirmation tool. As you can see, it is a 10-item scale that measures the severity of depression in individuals 18 years or older. All of these criteria are on a scale of 0 to 6. And it's pretty sensitive and correlates with a lot of the other skills in the research that's been done on it. And so you can see that there are common topics in terms of the sadness that the patient's feeling, how has their sleep and appetite been, their ability to feel, concentrate, and their suicidal ideation with the scaling here. So now that we have evaluated treatment-resistant depression, we'll move on to our drug of choice, Special K, also known as ketamine. And ketamine can be used for a ton of different reasons. You can see them here on the right hand of the screen in the box. But the one we are talking about is treatment-resistant depression. And so ketamine is a non-competitive antagonist at the GABA and NMDA receptors. And so when it antagonizes here, it causes this suppression of the excitement of the downstream glutamatergic neurons. And so what this does is it prevents the activation of the GABA interneurons and the downstream disinhibition of the glutamatergic neurons. So this results in a glutamate surge. And this glutamate surge then activates the postsynaptic AMPA receptors, as well as all these other downstream receptors. And this is what leads to an augmentation of the synaptic plasticity and synaptic strength within our brains. When ketamine is used for treatment-resistant depression, a typical dose is usually 0.5 milligrams a kilogram, infused over 40 minutes. And this is usually at a starting frequency of 2 to 3 times a week and could be down titrated to 1 infusion a week. Depending on the response and tolerability seen from the patients, the dose could be increased to 0.75 to 1 milligram a kilogram. And dose adjustments are not needed for hepatic or kidney impairment. However, for any BMIs over 40, adjusted or ideal body weight is recommended for the dosing calculations due to the large volume distribution for this drug. When the infusion is occurring, we want to get a baseline blood pressure and heart rate from the patient before, during, and after. We also want to monitor the consciousness of the patient as well to ensure that they're doing well and no dose adjustments are needed. Usually responsive therapy looks, patients start to see response within 24 hours, and this response tends to last on average for 1 week. There are quite a few adverse effects with ketamine. And so short term, what you may see is hypertension and anxiety. This hypertension is because ketamine has central sympathetic stimulation, and it also inhibits the catecholamine uptake with direct negative inotropic effects. And so this leads to increased blood pressure, heart rate, cardiac output, increased myocardial oxygen demand, and more. And because of these effects and increased blood pressure and increased heart rate, it has been associated with increased risk of cardiac arrhythmia and decompensation. And so any poorly controlled hypertension or previous heart conditions should be evaluated before starting this therapy. There are also usually transient adverse effects such as dissociation. And dissociation is disruptions of the consciousness, perception, memory, and affect. So patients may report this as feeling detached, feeling like they are daydreaming. They may report memory loss or just general depersonalization. There are also transient adverse effects of psychomimetic effects. So this is basically a psychotic state that may result during the infusion. If this is the case, you can decrease the ketamine dose and give a benzo such as diazepam as an IV push to help the patient. Patients may also complain in general of headache and nausea or vomiting. As you can see, there's a few contraindications to therapy. So any reported psychotic symptoms, as we mentioned before, poorly controlled hypertension, a history of substance use or dependence in the last year, and the patient being pregnant or breastfeeding. If patients were to use ketamine long-term, you want to monitor things like their urinary symptoms. There's actually such a thing as ketamine-induced cystitis due to ketamine being excreted through the urine and that causing epithelial barrier damage. You also want to monitor their overall cognitive state and their current substance use and dependence and history of it. There are quite a few routes for ketamine. However, IV has the maximum bioavailability and concentration available. And as I stated earlier, it has a large volume distribution. So it perfuses into the tissues rapidly, is metabolized by CYP3A4 and TB6, and is eliminated through the urine. So now we'll go through some of the studies I evaluated. And so this first study is evaluating the efficacy between twice and thrice weekly IV administration of ketamine to look at the initial antidepressant effects and the sustained effects. And so there were 4 study groups here. It was ketamine versus placebo twice a week, and then ketamine versus placebo 3 times a week. The primary outcome here was the change from baseline to day 15 in total score on MADRS. And the secondary objective was to assess the onset of antidepressant response and the safety of repeated doses. And so overall, in the study, the main change in MADRS score for the ketamine groups showed that ketamine significantly improved the MADRS score when compared to placebo. And so you can see here the overall scores. And so in the twice weekly dosing, by day 15, those using ketamine had a 68.8% response when compared to 15.4% in the placebo group. In the thrice weekly group, that looked like 53.8% in the ketamine arm when compared to 6.3% in the placebo arm. You can also see the general remission in symptoms by day 15, as well as the onset of clinical response. And at the bottom here, you can see the overall change from baseline on day 29 in their MADRS scores. And so in the ketamine arm for the twice weekly dosing group, this was 21.2 points when compared to 4. In the thrice weekly group, it was 21.1 when compared to 3.6. And so overall, looking at this, you can see that there was no differences between the two frequencies of ketamine and the twice versus thrice weekly dosing. However, the study was not powered to compare these head to head. It was more compared to placebo. But overall, they saw an increased response within 24 hours, and that response usually lasted throughout the 15-day period that they were being monitored. General safety events that were reported, the ketamine arms in both groups did report more treatment emergent adverse events. However, these were not statistically significant. Those events that were reported were headache, anxiety, dissociation, nausea, and dizziness. And overall, this trial showed that the treatment doses were equally successful, and there was a lot of improvement within the first 24 hours to 11 days. Study 2 was evaluating the maintenance doses of ketamine. And so it looked to see the effects of maintenance dosing and if weekly infusions were sufficient to sustain overall effects. And so the patients included here, they did need to have a treatment-resistant diagnosis of 2 or more failed treatments, as well as 2 augmentation strategies used. And this was a 3-phase trial. So phase 1 was testing the efficacy of ketamine with an active control, and that active control was midazolam. And so patients got 1 dose, and at least 7 days after that first dose, they would get the alternate agent, so ketamine to midazolam or midazolam to ketamine. Phase 2 was the patients after phase 1, they had to have a relapse in their depressive scores, so at least 80% of their baseline on their MADRS to start on phase 2, because the goal here was to reinstate an antidepressive response and evaluate the efficacy of these repeat infusions. And so patients got 6 open label infusions 3 times a week over 2 weeks. The patients that then responded during phase 2 moved on to phase 3, where they got 1 infusion every week for 4 weeks to see the overall antidepressant response. So here for phase 1, 41 participants did enter the study and received the 2 infusions on an average of 10 days apart. At the primary efficacy endpoint, participants had a mean decrease of 10.9 points in their MADRS score when they had ketamine first, relative to 2.8 points with midazolam. After 24 hours of their infusions, 27% of participants, or 11 of them, met the antidepressant response criteria, which was at least 50% of their MADRS score, and 5% of these participants achieved remission. In the next phase, which again was looking at the MADRS scores over the course of 6 repeated infusions, it was found that on average, participants' MADRS total score decreased by 2 points with each infusion. Of the 41 participants that went into phase 2, 39 completed the full course of infusions. And after phase 2 was over, 59% or 23 of these participants met the antidepressant response criteria, and 9 or 23% achieved remission. In the last phase, the participants who had at least a 50% improvement in their MADRS scores went into this phase. And what we saw was that there was no effect on time or with the weekly infusions on the MADRS total score. And so the ketamine infusions and the once weekly administration was sufficient to maintain the antidepressant response. So overall, 91% of these patients that were included in phase 3 maintained their antidepressant response throughout all those maintenance infusions. So overall, the study showed superior antidepressant effects with a single infusion of ketamine when compared to the psychoactive control of midazolam. And it also showed restoration of the antidepressant response with ketamine after a relapse of depressive symptoms. It also was consistent with other studies showing that ketamine did have an antidepressant effect at 24 hours post-infusion, and this lasted on average 7 days. And the study showed that more than half of study participants didn't meet response criteria, and almost a quarter achieved remission by the end of their 6-week ketamine infusions that were infused over the 2-week period. The antidepressant effects were cumulative, and depression severity was decreasing with each infusion. And so overall, in that final phase of the trial was the 23 ketamine responders. It showed that the weekly maintenance infusions were sufficient to maintain that antidepressant effect that was obtained with the repeated infusions seen in phase 2. The last study that we looked at was just evaluating the overall dose strength that's used. And so this was looking at 4 different ketamine doses, so 0.1, 0.2, 0.5, and 1 milligram per kilogram. And this was compared to a placebo dose of midazolam. And patients were evaluated at study days 0, 1, 3, 5, 7, 14, and 30 for their overall safety and efficacy. And the primary outcome measure was just looking at their 6-item Hamilton Depression Rating Scale to see if there was a response of 50% or greater reduction from baseline. So overall, what we saw here was two comparisons. One was ketamine, all of the ketamine infusions compared to midazolam, and then all of the infusions separated. And so there was a statistically significant result in both categories with the overall ketamine efficacy compared to placebo, so midazolam, as well with all the doses separated. It was found that the 0.5 milligram per kilogram and 1 milligram per kilogram arms did result in that more than 50% baseline reduction in the Hamilton score. And that 0.5 milligram per kilogram was superior to placebo when accounting for all the group comparisons and baseline characteristics. There were increased side effects reported with the increase of ketamine doses, and those were headache, nausea, vomiting, depression, and some high blood pressure readings, but none of these were statistically significant. So overall, the results of this study showed that there was efficacy in the 0.5 milligram per kilogram and 1 milligram per kilogram doses of ketamine, and there was no clear, consistent evidence for any of the lower doses used. And so with our patient, we discussed the value of ketamine therapy and what we think that it could do for her, and she decides to pursue this treatment. And so what are appropriate counseling points to bring up before starting therapy? A, she should not be pregnant before starting therapy. B, she should expect to start seeing results within 24 hours post-infusion. C, side effects could include headache, infusion-related reactions, and more. Or D, all of the above. Okay, so I see a D in the chat, and that is right. We want to counsel her on all of these items and more. And so now I just want to go into the discussion of other things that can be considered when talking to patients with treatment-resistant depression. And so first is cognitive behavioral therapy. And so this is a psychotherapy with techniques aimed to correct the incorrect belief in those with psychological disorders that their lives are filled with failure, hopelessness, and uselessness. CBT has proven to be beneficial as antidepressant therapy and alongside antidepressant therapy to reduce depressive symptoms in patients. It's been shown to have almost the same effect as medications for patients that have moderate to severe depression. And there's actually a study that evaluated the role of CBT alongside ketamine, and it found that CBT was actually able to prolong the effect of ketamine almost as a maintenance dose after ketamine therapy was completed. And so patients didn't relapse in their depressive state after ketamine was completed, but instead were doing well with just weekly CBT. And if they were to relapse, it was after they completed their CPD or CBT. Next is esketamine. And so this is actually a derivative of ketamine. It is a more potent glutamate NMDA receptor antagonist, and it comes in a nasal spray formulation. And so patients would get a first dose of 56 milligrams, or depending on the efficacy and tolerability, can go up to 84 milligrams. And the dosing strategy is usually on weeks 1 through 4. They would get it twice a week. And then week 5 and ongoing, they can get weekly or every other week. And as you can see here, the nasal spray is 28 milligrams. And so patients will have to get either 2 or 3 nasal sprays in one sitting. And so they should have a 5-minute rest between each dose. Esketamine is thought to have less side effects than ketamine. However, there are no head-to-head trials comparing the efficacy or side effect profiles of the two agents. And esketamine still has side effects of distorted sense of taste, vertigo, dissociation, somnolence, and dizziness. Next is brain stimulation. So the first agent is electroconvulsive therapy, also known as ECT. And so this is actually one of the best established therapeutic options for treatment-resistant depression. However, the mechanism of action is unknown. What it is a series of high-frequency electrical pulses to either the non-dominant right hemisphere in vertex or bitemporally. And it produces a self-terminating generalized tonic-clonic seizure. This is a pretty invasive procedure, and it does have a lot of stigma surrounding it. And so because of that, the American Psychiatry Association recommends ECT as a last resort. However, if a patient were to pursue this therapy, it is usually applied 2 to 3 times a week for 6 to 18 total sessions. Like I said, this is a pretty therapeutic option. 38% of patients who do ECT therapy see complete resolution in their symptoms within 1 week. 61% of patients see complete resolution within 2 weeks, and 81% see complete resolution in their symptoms after the whole therapy session has been completed. The other option for brain stimulation is repetitive transcranial magnetic stimulation, or RTMS. And so this is actually a non-invasive therapy. It's focused pulses of an electromagnetic coil over the scalp, and it does not produce a seizure. However, this is a daily treatment and requires several days to weeks for symptom response to occur. And so with this, patients who do pursue RTMS have been found to, it's been 5 times more likely for these patients over placebo, and there was only a 4.5% discontinuation rate. There is current investigations ongoing to see if rTMS therapy can be accelerated to being multiple treatments in one day and then being tapered to daily treatments to a lesser frequency than that. However, with that, there is increased discomfort and higher discontinuation rates than previously seen. So overall, to summarize, treatment-resistant depression is not an official diagnosis in DSM-V, nor is it consistently defined. And so when treating someone for treatment-resistant depression, you want to confirm that they did undergo therapeutic and correct durations of therapy of antidepressant agents. There's a lack of guidelines that talk about the optimal treatments for treatment-resistant depression, and many of the options do have a lot of stigma surrounding it. So when talking to patients about this, care is needed to pick the appropriate option. However, ketamine is a therapeutic option that is a racemic mixture of the S and R enantiomers and has an affinity for multiple receptors. And randomized trials have demonstrated that it can rapidly improve treatment-resistant depression and suicidal ideation. So thank you all so much for coming. That is my grill on ketamine and treatment-resistant depression.